Good morning and welcome to our ENDO 2023 news conference on our new Hormones and Aging scientific statement. We're really happy that you're all here today. My name is Colleen Williams and I'm the Senior Manager of Communications here at the Endocrine Society. We're pleased to have with us today Ann Coppola of the University of Pennsylvania, Rita Kalyani of Johns Hopkins School of Medicine, and Cynthia Stunkel of the University of California, San Diego. Over the next 30 minutes, each of our speakers will present their findings, and then we will end with a Q&A session. Please note that the news conferences are being broadcast live via webcast, and there are many journalists online with us right now. Because we're broadcasting live, it's important for all remarks to be made into a microphone to enable those who are joining us virtually to be able to hear what's being said in the room. Journalists who are attending online will be able to type their questions into the chat at any point during the news conference, and we'll address those during the Q&A. I would now like to invite our first presenter, Dr. Coppola, to speak.
Thank you, Colleen. It's a pleasure to be here. Thank you all for coming, both live and virtually. I'm very excited to talk about this statement. I think it's a really great thing for the Society have done. And I'll start with what the goal was, which was to provide a high-level summary of the current state of research in aging across multiple hormonal axes and to identify areas in need of future research. So really what we were trying to do is to provide a really concise summary across each of these areas. And then the exciting part that I think is a little different than some of the other things you may read about is where should the research be going? There are multiple hormonal changes that occur with age, and so we really couldn't limit ourselves to just one gland or even the few that we commonly think about. I think a lot of people think about changes in the growth hormone axis and the reproductive axes, but aging is occurring throughout the body, and so we really wanted to claim all the axes when we were thinking about writing this statement. And one of the main questions that came up is, how do you tell the difference between aging and disease? And I'll talk about that a little bit, but it defines how we treat these and how we think about the research. And so what we ended up with were 9 areas in the scientific statement. And the first 5 were our traditional hormonal axes, so changes that are attributable to the age-associated changes in hormonal axes, growth hormone, adrenal, ovarian, and testicular, and I did the thyroid axis. And we have an amazing group of authors here. And then we thought it was also important to include other age-associated hormonal alterations. So we have osteoporosis, vitamin D deficiency, type 2 diabetes, and water metabolism. And today we have with us, after I speak, 2 of the authors of the statement that are here. So Cynthia Stunkel from ovarian axis, and we have Rita Kalyani from the type 2 diabetes axis. We wanted to, it ended up being a large document. You should not be intimidated by the document because each of these sections is only about 2,000 words. And so it's really a kind of a one-stop shop to be able to look across all these axes at once. And we also wanted people to think about what are these common themes that occur across all of these axes when considering what's going on right now and even the future of research. For each of these 9 areas, we had a standardized format where we talked about the natural history and observational data in older individuals. So what was the state of the field in older people, available therapies, clinical trial data, if it was there, on the efficacy and safety of the therapies in older individuals, then a quick summary of key points, and then scientific gaps. And at the very end of the whole piece, there's a summary of the common themes across the 9 areas. Now, this is just an example of why we need to think about what's happening in concert across the different axes. So this is a graph that shows hormones by age. It's cross-sectional data looking at females versus males at the estrogen and testosterone, so the reproductive axis on the top, then DHES from the adrenal axis in the middle, IGF-1 from the growth hormone axis at the bottom. And what you see is fairly substantial changes in these hormones over time. So for example, in DHES, the levels in someone in their 70s are about 20% of what they are when they are in their 20s. And so it's very reasonable to say, what are the potential implications of these very dramatic changes that can be occurring over time. The other thing to think about with this is menopause is a fairly discrete event, whereas for the others, at what point does any change in these hormones become clinically important? These declines are starting to happen fairly early in life, and at what point would you want to intervene, if so, and with what level and what type of hormone? So I'm going to talk about some of the common themes that came across and then the common conclusions. So one of the common themes was to explain the correlations between age-associated phenotype and lower hormonal output across cellular axes. And so several of those hormones are in particular known for what were called the anabolic hormones. Hormones that can build muscle, can build bone, and so certainly we see changes in muscle and changes in bone over time, changes in energy level, sexual activity, and so how much of that is causal? How much is because of these changes, or how much is it just along for the ride with what else is happening with aging? So they're caused by aging or some of the other things that happen as we get older, where there's a decrease in activity level, increases in other conditions that can be in fact affecting the hormones rather than the other way around. We really wanted to see if we could identify some of the fundamental causes, so get at the root of the mechanisms underlying this. And that relates to some of the basic sciences out there and even to this field of geroscience that's out there that you may be hearing about. We're trying to find common therapies that could affect multiple areas simultaneously. And so we wanted to understand where some of the common themes that we know are aging associated, where they fit in with the fundamental causes of the hormonal changes with age. We wanted to make sure that appropriate and different types of animal models are used. So for some of these hormones, what happens in some of the rodent models that are commonly used is not what happens and doesn't parallel what happens with human models. And so we want to have the model system fit the model that's going on there. And so we need to use aging models, right, older animals, but even these animals that can be called humanized, as it were, so that they have the same type of programming going on as happens in humans in these models as well. The hormone assays are very important, as are the reference ranges. And so to be able to compare across studies, to compare older to younger, compare different study populations racially, ethnically, males versus females, we really need to have standardized hormone assays and harmonized reference ranges, because otherwise the comparability becomes very, very challenging. And as I alluded to when I showed that slide with the figure, really need to think about the timing, dose, and target population. So I have three conclusion slides. The first is research is needed to provide the evidence base to support when hormonal therapeutics are appropriate, and equally importantly, when they are not. Hormones have been a frequent target for the anti-aging industry, despite evidence that supports harms of growth hormone sex steroids outweighing benefits in unselected populations of older individuals. And we advocate for prescribing that is evidence-based. So hormones have these almost mythical qualities to some people, that if I just had my hormones back and my hormones were back the way they were, they would all work out. And what we want to do is to make sure that patients are being treated appropriately, that their symptoms are being heard and managed and ascribed to the appropriate problems and not necessarily to hormonal problems when they are not. So I think part of what we need to do is to get out there the evidence that we have, which includes evidence of when not to prescribe as well as to prescribe. We would like to see more appropriately powered, randomized, controlled clinical trials that are specifically in older people. And 65 is often that cutoff that's used to divide older versus younger. We really need to be looking at people in their 80s and 90s as well as the population ages to understand what's going on in our oldest old. We need to look at outcomes that include measures of physical and cognitive function. Those are the things that we're really thinking about as people get older, and we need to make sure that we're measuring what the relationship is to these hormones, and if we're intervening, make sure that we have the right outcomes and the right readouts to understand the impact of these therapies. Safety is a critical issue in older people, and understanding that over time how these drugs are metabolized in older people, pharmacokinetics, we need to understand that as well when we're thinking about prescribing. And then we've taken this approach in the past of thinking about each of these hormones individually, but could there be combinations and other interventions such as exercise and senolytics that broadly target fundamental aging processes? And so we need to have this be in alignment with what's going on in the geroscience literature as well. I'm going to make one quick plug for exercise before I move on, because that is the one therapy that really does have multiple effects across these hormonal axes. For example, testosterone levels go up with exercise. We know it improves insulin sensitivity, so we're also impacting the diabetes part of it, and it helps with bone density, the osteoporosis. So the way to target multiple areas at once, exercise is the best that we have, even though people would much prefer to try to take some kind of supplement. We need to keep reinforcing the benefits of exercise. And then my final slide is that hormonal modulation may also benefit non-endocrine diseases such as cancer, especially through therapeutics with target-specific actions. So we've been talking about how supplementing the hormone could be useful, but we also know that at times when we try to suppress or act to block the receptor in certain cancers, that could be beneficial as well. And so thinking beyond just the simple model of we need to just provide hormonal therapies. Approaches to preserve or revitalize gland function should be developed and tested, and I think this is a particularly exciting area to think about in the future. Is there a way that we can help the glands that are already there function better? Because if we could do that, the underlying systems and the feedback loops and the adaptability that occurs minute to minute and hour to hour is much better with an endogenous gland than what we can do with any kind of supplementation. So I think that is a really exciting area of research that was kind of across many of these different axes and different areas. And permeating this research should be inclusion of representative populations by race, ethnicity, and environmental exposures. We need to consider that in all cases, and often the research that we've seen has been pretty narrow. And so with that, I think that really is my last slide. I'm going to let the rest move on. I think we're taking questions at the end. Is that correct? Yep. So please, we'd love questions, so give us lots of questions at the end.
Thank you so much. Thank you so much, Dr. Coppola. I'd now like to invite Dr. Kaliani to speak.
Thanks so much. It's a pleasure to speak briefly about diabetes and aging, which, as Ann mentioned, was one of the sections covered and a focus of much of the work that I do as well. So we know that diabetes is perhaps one of the most prevalent endocrine conditions out there with tremendous public health implications. The most recent estimates have 37.3 million people in the United States with diabetes, 11.3% of the population. And specific to older adults, 1/4 of our older adults aged 65 years and older have diagnosed diabetes. This is the highest of any age group. Perhaps more concerning is that 20% of them don't even know they have it. And so this behooves those of us in the field to really think hard about how we can even diagnose people with diabetes in older age so that they can get the treatments that they need. In addition, 1/2 of our older adults have prediabetes. So if you put those numbers together, 3/4 of our older adult population have some form of glucose abnormality. That's a tremendous number of people who really could benefit from earlier intervention. We also know that people with diabetes are living longer, which is fantastic, but it also means that they may have the opportunity to accrue more complications from diabetes as well. And while microvascular and macrovascular complications have been generally improving in the population, we know that the oldest age groups are still at greatest risk of developing these complications. So it's clear that the burden of diabetes and its complications in older adults continues to be significant. Further, if those numbers weren't enough, the numbers will only continue to grow, more than fourfold if you look at some of the extrapolations that have been done by 2050 in terms of the number of people with diabetes over the age of 65. Diabetes is costly, $327 billion in 2017, up from $245 billion in 2012, and most of the cost for diabetes care in the United States is provided by government insurance, of which Medicare is a large proportion. And so this is not only a disease that has Tremendous personal burden, but also societal burden as well. So what happens with the aging process that makes people more vulnerable to developing diabetes? Well, we know that impaired glucose metabolism is often described with aging, and this is really at the level of tissue sensitivity to insulin, insulin being the main hormone, as we know, that increases glucose uptake, particularly in the postprandial state, and primarily at the site of skeletal muscle, liver, and adipose tissue. We know that that peripheral insulin resistance increases with age, the sensitivity goes down, and we also know that people, as they age, likely produce less insulin from their beta cells as well. So it's a combination of both peripheral insulin resistance and also decreased insulin secretion from the islets. So why does this insulin resistance occur with aging? There's been lots of potential mechanisms investigated. We know that there's body composition changes that occur with aging. People tend to decrease or lose their muscle, their lean body mass, in parallel with increasing body fat. So people may not notice much change in their overall body weight as they age, or maybe may gain some weight, but really the composition underlying the body weight does change significantly with aging and lends itself more to keeping people at higher risk of insulin resistance. We know that there are important lifestyle changes. As people get older, in general, more sedentary, may not exercise as much. You heard Ann talk about the importance of exercise, and we have seen this in general populations of older adults, that this does occur as well in general as people age. There's a decline in mitochondrial function. We know that mitochondria are very important and often called the seed of where insulin resistance may start. And so as mitochondrial dysfunction occurs with aging, this may also underline some of the insulin resistance that we see. There's important hormonal changes, and so again, this gets to the fact that multiple axes really interact in the older adults, lower IGF-1 and androgens such as testosterone that are seen with aging. There's increased oxidative stress and pro-inflammatory markers as well with aging, which could increase the risk of developing insulin resistance. So why is this all important? Well, the way that diabetes presents in older adults may actually be very different than in younger adults. And that is manifested by this slide from the Baltimore Longitudinal Study of Aging. In the dark black line, you can see that 2-hour plasma glucose levels after a 75-gram oral glucose tolerance test, really the proportion of people that have a normal result, those with normal glucose tolerance, goes down much more steeply than those who have what we call impaired fasting glucose, which is in the light black line above. So what this is suggesting, and this is the rate of progression from impaired glucose tolerance to diabetes in the bottom line, and impaired fasting glucose to diabetes in the top line. So if anyone's gotten screened for diabetes in the past, we have 3 criteria: fasting glucose, A1C, or 2-hour glucose after a glucose tolerance test. I think we can all surmise that the 2-hour glucose tolerance test is the most cumbersome and is least performed. But based on this slide, you could argue we may be missing a substantial proportion of our older adults who actually have impaired glucose tolerance. And to really underscore that, when you actually look at fasting glucose levels and 2-hour glucose levels, this is in men, but the slide in women is very similar, you can see that the 2-hour glucose levels rise much more steeply with age than fasting glucose levels do. So again, this gets at the idea that diabetes in our older adult population may present differently and may also require different therapies, really, in order to address the primary pathophysiological defects that occur with aging. So we know diabetes has many complications, what we call the macrovascular and microvascular complications, but in older adults we also think of geriatric syndromes because these also occur at much higher frequency in our older adults with diabetes. People with diabetes, as they age, are also at increased risk of functional limitations, difficulty walking or mobility difficulty, accelerated muscle loss. We actually have studies that show that they lose muscle a lot faster than their counterparts with aging, and then physical disability and frailty. In this review that we had done now 10 years ago, we described all the geriatric syndromes that occur at greater frequency in people with diabetes compared to those without, including falls, vision loss, hearing loss, urinary incontinence, cognitive impairment and dementia, depression, and frailty. So when we talk about diabetes in older adults, it's not just that they're at higher risk for heart disease and kidney disease and eye disease, which are clearly very important, but there's also these host of geriatric syndromes that we have to screen for and treat, not only to improve quality of life, but also to generally just reduce the burden of diabetes and its complications in older adults. We also know that it's not just the high glucose levels that are problematic, especially in older adult with diabetes who may lose the ability to respond to low glucose levels, what we call the counter-regulatory hormones. So this is a slide that demonstrates that in older adults with diabetes, that those with the greatest number of hypoglycemic episodes, low glucose levels, actually had the highest risk of developing dementia. So this complicates how we treat people with diabetes as they age. It's not just reducing glucose, but it's also minimizing hypoglycemia. And to add to the mix, we also know that the treatments we use can also put people at higher risk for those geriatric syndromes. So in this slide, insulin therapy, which is shown in the dark black bar compared to diet or oral therapy in the gray bar, and no therapy, in people with diabetes, you can see that those who are on insulin are at the greatest risk of developing falls. And perhaps that's linked to the hypoglycemia that occurs, perhaps it's linked to the severity of diabetes and its complications, but it begs the question of how do we optimally treat our older adults with diabetes to minimize morbidity? I talked about mobility limitations that can occur in older adults with diabetes. This is a slide from the CDC that demonstrates that almost half of adults with diabetes have some form of self-reported mobility limitation, and this is really across sex and across races. Further, as people live with diabetes longer, they also lose more muscle and they lose more muscle strength. And so this is a study that we had done a while ago demonstrating that as people live with diabetes longer, their muscle strength actually goes down as well. And then lastly, talking about frailty, we often speak of frailty in common parlance, but this is a medical definition, if you will, that we have used to study in research. And in this definition, it's a clinical condition characterized by increased vulnerability to stressors and a risk of adverse outcomes, including disability, hospitalization, and death. There's 5 criteria that you can read there: shrinking, weakness, poor endurance, slowness, and low activity. I'm not going to go through them in detail, but you can see some are self-reported and some are objective, for instance, based on low grip strength, low walking speed, or even low BMI. In this definition, to have frailty, you have 3 or more of these criteria. Pre-frailty is 1 or 2, and non-frail is none. And so in a study done in the cardiovascular health study using this definition of frailty, which is one of arguably, I'd say, more common definitions that we have seen in the literature, those who are frail have the highest percentage of diabetes compared to those who are pre-frail versus non-frail. And so we think not only about these geriatric syndromes, but also these functional consequences of diabetes as well: the mobility limitations, the muscle loss, and the frailty. In this Endocrine Society clinical practice guideline that was published in 2019, perhaps it's not surprising then when you look at the treatment targets that are recommended, that there's both, in those on insulin at the very bottom, there's both a target for under a certain number, for instance, under 7.5% in those in group 1, but also a recommendation for what number you shouldn't go below, above 7%. And I would say that this is one of the probably best aspects of this guideline compared to other diabetes guidelines out there, is that the Endocrine Society really emphasizes the importance of minimizing hypoglycemia and the way that these target ranges are listed, especially in those who are on insulin who are at high risk of hypoglycemia. I didn't share the other recommendations that are in this, but they also recommend that everyone be screened for functional status if they have diabetes in older age. And how often that's actually done in practice? I mean, probably not as much as it should be, but again, it also translates into the way that we identify the presence of some of these comorbid syndromes. So in summary, diabetes in older adults is a growing health burden. Persons with diabetes are living longer and are vulnerable to the traditional microvascular and macrovascular complications with diabetes. In fact, they have the highest burden of these of any age group, but they're also much more likely to experience geriatric syndromes such as falls, dementia, depression, incontinence, mobility limitations, muscle loss, and frailty. Up to twofold higher compared to those without diabetes. And further studies are needed to better identify those older individuals who may be at the highest risk of these complications from diabetes. Thanks so much, and I'll turn it back to Colleen.
Thank you so much, Dr. Kalyani. We'd now like to invite Dr. Stunkel to present.
Good morning, and thank you so much. I think it's really exciting to have this statement come out. I really am pleased to have been part of it, and I appreciate your interest. And my part is going to be talking about the ovarian axis. I do serve on a data and safety monitoring board on behalf of a company that is investigating a new estrogen, and I will not be addressing that. So you already heard from Dr. Kapala about the way that our sections were structured. And so when I'm talking about the ovary this morning, even though there are so many things we could talk about, I'm going to primarily address the key points in my section and then touch on some of the scientific gaps. But I hope that you get a sense, as I did in preparing this, for just how interested people are in this topic and how important it is and how much scientific activity there is around it. I just really came across this editorial in Nature Aging. It was a one-page thing by their editors, just emphasizing how important the topic of ovarian aging research is. And I'm into PubMed and looking all the time, and I was kind of amazed to see, as we were putting this together, and every time we'd have a little restructuring of the time, how many more new papers had come out. So at least 1,200 publications in just the last few years. So this is a hot topic, ovarian aging. So the first key point is that menopause and the postmenopausal state are natural, pre-programmed manifestations of ovarian aging. And the other caveat I wanted to put in that's not formally written, I don't think, this is a universal experience. If you are a woman and started out reproductively competent and live long enough, you will experience this transition. So we can't say that about too many things in medicine, that it's going to be a universal experience. The two key characteristics are fertility lost and reduced ovarian hormone production. There is no question that the compromise of ovarian reserve and fertility loss is incredibly important to women. But what we really focused on in this aging statement was primarily looking at older women, which I'll define as 50, that I actually think is really young now, and the hormone issues that evolved. So I put this as the first sentence in our statement, that in contrast to other endocrine axes, aging of the human ovary is programmed before that little girl is born for midlife senescence. And let me just show you, and this is kind of a model of reproductive aging that has withstood the test of time, but if we look before birth, so it's 7 months gestation, 6 to 7 million follicles in the ovaries of this little girl, and even by birth this number has dropped to just 1 to 2 million. You can see the curve, and as it progresses, that there is kind of a more rapid slope and a faster decline as one gets older, until finally, about the age of 51, menopause, or the final menstrual period, occurs when there are really just about 1,000 follicles left in the ovary. So questions come up, and when I'm talking with the medical students, we talk about some of the primary ovarian insufficiency and some of the mechanisms that can speed or hasten this curve, such that women are going through menopause in their 30s, and they're always asking me, Dr. Stunkel, what can we do to slow this down? And that really is one of the scientific questions of the moment. What can we do to slow this down? And so some of the gaps in the research are thinking about factors that affect the timing and consequences of menopause. I'll talk some more about that. But we're really starting to appreciate some of the difference racially, ethnicity. Studies like the SWAN study, the study of women's health across the nation, have helped us learn more about that. But we're learning that lifestyle things, as Dr. Coppola talked about, genetics, a huge influence, and increasingly environmental influence of exposures that affect endocrine systems can also be factors. So this is my Brave New World slide. These are things that we included, we mentioned in the statement, but I really don't want to go into detail about these. But I want to express again the expansive interest. Number one, I would say that the first part is trying to just get one more egg out of that ovary in a woman who's trying to conceive, and some of the ways that that might happen. And then finally, there are a number of different agents that are under study now looking how can we maintain ovarian fitness or revitalize our ovaries to promote reproductive longevity. So turning to a more clinical aspect of aging, we know that menopausal symptoms, once women reach that point on the curve where they have stopped menstruating, are very common, but they vary a great deal from woman to woman. And the other thing is that if a woman so desires, and depending on her degree of bother, we certainly have the options to effectively treat some of these symptoms. Now, this is kind of a cast of characters of symptoms and signs that we are learning now become even prevalent and are relevant during the years prior to the last menstrual period, which we call the perimenopause or the menopause transition. And of these things, that some are central, some are metabolic. We see a higher incidence of metabolic syndrome. Fertility issues and certainly bleeding changes are kind of the sine qua non of what's happening with menopause. But vasomotor symptoms, hot flashes, that's the number one symptom, probably 85% of women. And we've also learned from these longitudinal studies that these symptoms can start fully a decade before the last menstrual period, and for some women can go on for perpetuity. So one can be highly motivated to treat these. So there have been a couple other interesting things that are coming out that are studied right now, looking at the natural history and the physiology of vasomotor symptoms or hot flashes. What are they really? Why do they occur? What do they imply? And I used to just think that I pushed back quite a lot on some of this research because I thought this is aging, this is normal, this is natural. But I'm increasingly convinced that that there are some issues that tie in vasomotor symptoms with cardiovascular health. We don't know exactly which is the chicken, which is the egg, but we know that, for example, in some of the women who had their menopause way back in their rear view mirror and have a recrudescence, their hot flashes come back. What does that really mean? We know from the SWAN study that there can be an increase in carotid intimomedial thickness as well as heart attack and stroke, actual cardiovascular events in women who have early and persistent hot flashes. And these are monitored now in these studies for over 20 years. So this data is observational, but it's quite compelling. And the good news is that there are some really fine investigators on this, but there's going to be more in the future to help us understand that. Okay, so how do we treat it? How can we fix it? How can a woman, be addressed when she says, can you just take the edge off? I just want a good night's sleep. And so there are all sorts of things. Some women who lose weight will have their hot flashes better. There's cognitive behavioral therapies and hypnosis, what I like to call aisle number 4 at Costco, with all kinds of supplements that we don't really know if they help or not, but they make some women happy, and if they're safe, I don't push back too hard. The prescription therapies that we have used include some of the antidepressants, the SSRIs, the SNRIs, gabapentin, a drug for neuropathic pain. But I wanted to let you know about the new kid on the block that relates to the kisspeptin, neurokinin Y, and dynorphin hypothalamic neurons. We call these the candy neurons, which helps me remember it. But it controls not only vasomotor symptoms, but also some gonadotropin and sex steroid secretion. This is really a whole new game. And this was originally described by a woman named Naomi Rance. I personally think she should get the Nobel Prize for Science for sorting out what's going on in our brains that contributes to these things. But this agent was just approved by the FDA just in the last month. feasolinatant, and this is the first oral non-hormonal selective neurokinin 3 receptor antagonist. It blocks these neurons to modulate neural activity in this center that controls heat and heat release, which is what a hot flash really is. It reduces hot flash frequency, severity, and women report better sleep. So this is a win. Symptoms are improved quickly and maintained through a year. And even though the critical trials that evaluated this looked at 2 different doses, it's the 45 milligram per day dose that was just approved. So there'll be more coming on this, but I think this is notable. Estrogen, however, we think, and I don't have head-to-head trial data of estrogen with this new neurokinin 3 receptor antagonist, still is the most effective. But estrogen is complex, and we've learned a lot in the last 30 years about how to do it better. The Women's Health Initiative was a large randomized controlled trial, not asking the question, will hormones help hot flashes? We've known that for 50 or 60 years. But the question was, will hormones provide a preventive strategy for heart disease, for bone, for cognitive health? What is the effect on breast cancer? What is the effect on just well-being? And this study initially, some of you might remember, came out in 2002, and this was kind of like the shot heard around the world because it didn't work, and there were more risks than benefits in women ages 50 to 79. So one thing that's happened in the last decades is that the investigators have really tried to tease out this data. And you can even see from the back of the room, there's a lot more action, there's a lot more trouble if you're in your 70s, and more trouble in your 60s, but the women in their 50s really have a very reasonable risk of using hormone therapies, and these were for conjugated equine estrogens and medroxyprogesterone acetate, a synthetic progestin to protect the lining of the uterus, and for conjugated equine estrogens alone. And so I think if we look at some of the current approach, we use lower doses. We sometimes use other estrogens. We might lean towards transdermal therapies and micronized progesterone. So my bottom line message on this is that in the right woman who is assessed appropriately on the front end, these are very safe. So the key points about the hormone therapy, initiation of estrogen or combined therapy is safest for those who are less than age 60 and less than 10 years since menopause. That makes sense, right? Your body is just healthier then, your cardiovascular system is healthier. If they don't have contraindications, which would be things like breast cancer, certain endometrial cancer, certainly any cardiovascular event or stroke in the future. And then we do recommend, and in our Endocrine Society clinical practice guidelines on menopause, that clinicians literally go through a risk assessment. We have these tools for, should a person go on a statin or whatever, literally go through that assessment for both heart disease and breast cancer prior to initiating therapy. How long should women take it? This is kind of an individual decision. In general, the guidelines recommend 3 to 5 years because we know that with more extended therapy, with some preparations, there could be an increased risk of breast cancer. But some women go, I feel so much better. I do not want to stop. And then we recommend annually reassessing this. And sometimes it has to be a little bit of a shared decision making. But I think we should credit women with having the ability to participate in this decision about what they want to do. And even though oral hormone therapy has been studied the most extensively, again, as I mentioned, and based on observational studies, lower doses can certainly take the edge off. Transdermal therapies, I like to say, are more metabolically friendly and have fewer undesirable effects and possibly fewer cardiovascular events. So that almost concludes my comments. We still have more to learn, and that's all this last slide says. And we really need more clinical trials. We need trials designed, not like the WHI to say, will it prevent things, but look at young women who have hot flashes, who are the ones who are going to come in for therapy, and follow them long term. We need some head-to-head trials. We know these agents work, but it would be really nice within the same population to be able to weigh some of the risks and the benefits. So you could say, I know you want an oral estrogen, but estradiol is really better in these ways than conjugated equine estrogen, or maybe the converse. And then finally, there is a therapy of a SERM, basodoxifin, that is melded with conjugated equine estrogens. The trade name is Duovy, and this was not available for a while and is coming back on the market. And again, we'd sure like to see some clinical endpoints. In particular, I'd like to see a clinical trial looking at breast cancer with this combination. So thank you so much for your attention. I will stop and look forward to your questions. Thank you.
Thank you so much. Thank you all for the presentations. With that, we'll open up the Q&A if anyone in the room has a question, and then we can check with the reporters online too.
Hi, Jill Roulette with Helio Endocrine today. Can anybody talk a bit about quality of life versus quantity of life? And maybe this is two-part. Once you lose it, can you get it back?
So I think the ideal is quality of life, right, over quantity of life. And the ideal way to live would be to have full function and that at some point just not wake up, right? That's really the goal. And I think that's a shared goal when we're thinking about what the research should be, is it's not about how long you live, but it's about the quality of life. And so not thinking aging is normal. To get older, you have to get older, you have to age, but it's really about quality of life, physical function, cognitive function. That all ties into what we think of quality of life. So I absolutely think that's what we are thinking in terms of the goals, and not the cosmetic, do I look better as I get older, which I think some people really is the focus on aging. And I think there was a second part to your question too. That
Once you lose it, we lose muscle mass as we age.
Right.
Can we get that back?
Yeah, so that's a really great question. I think one of the things that I'm glad you brought this up is there should be more of a focus on prevention, because it is hard once you lose it to get it back. And even something as simple as, a hospitalization where you're bedridden for several days, and people have done these studies in healthy people, they end up having to give rehabilitation to older people afterwards just from doing a study where they were hospitalized for several days. So it is very hard to get it back once you lose it. And so the goal is to not lose it to begin with. But then I would also say part of it is how quickly can we help people get it back once they have lost it. And maybe it's not quite to the level they were before, but try to get them quickly and to as much of an extent that they can to that level. Absolutely.
One of the brave new world things that's being looked at in the menopause world is we know that the hormonal changes primarily are this drop in estrogen that occurs with menopause. But the second hormone, the pituitary hormone that regulates the ovaries, is called follicle-stimulating hormone, and we know that that goes up. And that has always been a marker for, is this woman in menopause? Or it's even used in fertility, like, well, what's her ovarian reserve? How close are you getting? So there were some really amazing mouse studies, but there have been things starting to look in people, too. That was in the New England Journal a few years ago of sort of a potential clinical implications of basic research. And they made and so we've always thought of FSH as just like this marker, right? And what they did was they looked at these animals, and, the little mice with having their ovaries removed had a higher FSH, and their fat tissue changed. They had more adiposity. Fat tissue moves. Any woman will tell you this happens. And their bone density was compromised. And so they made an antibody to follicle-stimulating hormone, dropped the FSH way low, and these little animals got their girlish figure back, their bone density increased, and their muscle mass increased. So it was quite a remarkable change from, I think it just gives a good example from this follicle-stimulating hormone that we had just kind of said, this is a marker. And maybe in the aging person, this has much more of an impact. So people are starting to look at follicle-stimulating hormone in women a little bit more, and we're not there yet to say, are you ready for your blocking antibody? But that there may come a time. So I look at that as a way to reverse some of these changes, and that would be a really positive thing.
I'll just add to that, perhaps diabetes is one of the conditions where we have, set targets of care. And I do think that that's the direction we need to be going towards, which is focus on quality of life, exactly as you said. And there are studies that focus on quality-adjusted life years lost, not just life years lost. And I think that's important, the functional life years. And it may not be mutually exclusive, the quality of life and the quantity of life, right? So we talk about expected life expectancy and using that to inform targets of care. Because it may be, changing the vision, the long-term vision of complications over a long period of time to really focusing on how the person in front of you is doing right now and optimizing their quality of life. So I do think it takes a frame shift in some ways, but for many of the conditions we treat in older adults, really the quality of life, if you ask the person living with the disease, it is probably what matters most to them.
Great, that's all the questions we have in the queue.
Thank you again to all of our speakers and for everyone joining us here and online today. As a reminder, the recordings of these news conferences are going to be available on our website and YouTube channel. And if you have any questions or would like to set up an interview with one of our speakers, please feel free to contact us at media@endocrine.org.
That was fun. You learned something. That was great.